Now we are going to have a joint lecture done by Dr. Corrado and Dr. Jaira Almonte. They are both all NYC faculty members. Dr. Corrado is the Assistant Program Director at NYP Presbyterian Columbia Cornell, and he's also the Medical Student Clerkship Director in Emergency Medicine. Dr. Almonte is awesome. He's dual EM trained and PEM trained. He's also the Assistant Program Director for Elmhurst Mount Sinai Medical Center. So welcome, guys, and we're looking forward to hearing your take on this controversial topic, especially in light of COVID. Should we be doing direct laryngoscopy or video laryngoscopy? Thanks, guys.
All right, good morning. Thank you all. It's wonderful to be here. Before I start, I'm Jaira Almonte.
And I'm Mark Corrado, faculty at Cornell and one of the APDs at the Columbia Cornell program. Just click here. So what are we going to be talking about here? Specifically, we're going to be talking about how we in New York City in 2020 should be doing laryngoscopy. Now, the debate is pretty well developed at this point between video and direct laryngoscopy. But what we'd like to do is tailor it sort of specifically for you guys, for this audience.
Yeah, I think instead of trying to answer the question of what is the best way to intubate, what we want you all to keep in mind as we go through the evidence in the next 20 minutes is how should I be learning to intubate into resident in 2020? I mean, your training time is really an opportunity for every patient encounter to maximize your development of skills. But at the same time, you have to maintain the safest possible patient care environment. And we want to figure out how to help you do that.
So look, we all recognize that difficult intubations, different airways are a bear. That's why we're using this little analogy here. You know, if you look at this cute little guy with his small mouth and his micronathia and his obesity, and you know, airway management is probably the single most important physical skill that there is for an emergency doctor. So establishing and improving best practice in this arena really is time really well spent. So I just want to start by getting everybody sort of on the same page and getting together on exactly what it is that we're talking about. You know, look at the panel on the left. Historically, direct laryngoscopy was the only option. And it's called direct laryngoscopy because you have to establish a direct line of sight, shown by that straight red line, a direct line of sight between your eyeball and the patient's glottic opening. And you do this by manipulation of the blade and patient positioning, and you know, manipulation of the airway with your right hand. And Jock, that's not always easy to do, is it?
No, I mean, I think it's really challenging in a lot of patients and, you know, totally physically impossible in about 1%. And you can't always predict who those are going to be. And so in the early 2000s, someone had the brilliant idea to put on a little micro camera on the end of a laryngoscope blade to get a better view. And so video laryngoscopy was born. And the initial kind of devices that really took off were these hyperangulated blades like the glide scope you can see on the right, where there's a radical curve at the end of the blade that allows you to kind of get around the tongue and kind of look up at the glottic opening rather than having to develop that line of sight.
Yeah, so that's that curved red line that we see in the photo. So what these hyperangulated video laryngoscopes allow us to do pretty much is see around a corner. So seeing around a corner is good. And I think it's actually worth watching that again. Whoa. So anyway, so once there were two options for intubating, and you know, by this point, video laryngoscopy is pretty much ubiquitous in all of our departments, it led to a big debate in the literature and in the FOMO-sphere on which is actually better. Over the years, the debate it's kind of gotten heated and passionate at times. Some people are of the belief that direct laryngoscopy is a skill that's absolutely essential for emergency physicians and should never be, you know, completely abandoned. And others, you know, some very wise people, such as Ron Walls, big airway guy, he said back in 2012, I will unequivocally state that it is wrong for people to practice direct laryngoscopy. So it's been a heated debate.
Yeah, I mean, I can't say I quite get with the Ron Wall's standpoint, but at the same time, I mean, take a look at what you get between video and direct laryngoscopy. Wouldn't you rather have a really great, close-up magnified view of the glottis, like you see on the right here, as opposed to sort of like staring down a dark tunnel? I mean, it just kind of makes sense, right, that this is going to be the better way to be intubating somebody. It certainly makes us feel better, I think. And I feel like we kind of, in some ways settled this debate for ourselves. I mean, you really don't know where a person stands on an issue till the chips are all on the table, right? And so this spring, we're managing all these high-risk COVID airways, and we made the decision to do it 100% video, essentially. I mean, granted, that was in part due to the theoretical risk of decreased exposure because you get out of the patient's line of spray of respiratory secretions. But also, if you look at like the COVID airway guidelines that Difficult Airway Society and others put out, they basically just said, we should be doing what's absolutely best for these patients, and that's video.
Right, but I think that's what makes this question even a more important issue to be thinking about. Most places are now doing 100% video, sort of by default, as you say. And I think it's really easy to envision a world 3 or 5 years from now where we have a generation of newly graduated emergency doctors who have never done emergency intubation with direct laryngoscopy.
Yeah, I think it's a good point. I think, we do want to be rigorous about this before we go and throw out, entire, decades of practice. And developing that skill for kind of getting that mechanical line of sight is probably important. But I mean, there is good literature that, at least for novice intubators, training in VL alone does improve your DL skills. So do we have to be doing this, in these high-risk emergency airways?
That's true. But what, it improves their DL skills, but what about developing real expertise? There's also literature to suggest that institutions with a high VL utilization, they see an erosion of their DL skills, which suggests that you really need to be doing DL to really establish and maintain expertise at it. So anyway, guys, these are some of the sort of passions of the debate, which, like we said, has become heated at times. But this is an EBM day, an evidence-based medicine theme day. So our job is going to be to put this big question of what is the better way to be doing laryngoscopy into the context of the literature that we have available to us. So let's kind of see where we stand. So, Jeff, is there any reliable evidence for the superiority of video or direct laryngoscopy?
Yeah, it's a good question, Mark. There's a ton of literature out there. I have to say, whenever I'm encountering the big field literature and I want to see what the answer is, the first place I'll go is the Cochrane database and look for a good Cochrane review. And thankfully, they did one on this topic back in 2016. It was like a huge effort, like 64 randomized controlled trials, all comparing various VL devices to DL. And I think we both looked at it. So, I mean, what was your take on this?
So at the time, their findings were really pretty significant. And it really propelled the argument for a total switch to video. They found a big advantage for video in terms of preventing failed intubations. They didn't find much of a difference in terms of first pass success, but they found that 1 out of every 14 video intubations would have failed if direct were used. And at the time, that was a really significant argument in favor of video.
Yeah, I mean, I guess, so if that's such robust data, then why are we even having this discussion?
Well, with that and kind of with the other evidence that we're going to talk about shortly, there's some really important and significant methodological problems with that meta-analysis. And the biggest thing is that, of the 64 studies that they included in their analysis, 7,000 patients or something, really only one of those studies, arguably up to 3, but really only one of those studies was really conducted in an emergency department. Most were from the anesthesia literature. So, the first really big problem is that, is with applicability to emergency medicine.
Yeah, I think that's a really good point. I mean, we can all agree that sort of elective anesthesia airway management is a different skill set and different procedure than emergency airway management. I mean, you got a person who's, been fasting for 8 hours, getting ready for their, elective plastic surgery procedure. is fundamentally different than intubating and crashing GI bleed on resuscitation day, right?
Yeah, and in that same vein is the problem of who was doing the intubating. Just as they weren't done in emergency departments, the operators weren't emergency physicians. The studies ranged from anesthesiologists to folks they just referred to as, non-anesthesiologist physicians. We all know any tool is only going to be as good as the person using it. And in these pooled studies, it was a pretty heterogeneous group of intubators. So, all this means it's just not really a reliable way to know that, if we in the emergency department are more likely to have success with VL over DL.
Yeah. Yeah, I think that generalizability EM is really important to think about. And also, I want to go back to something you mentioned earlier, that they really found no difference in all comers in terms of first pass success. And I was one of their secondary outcomes for the study, but I think as EM providers, that's really what we ought to be looking at when we decide what to do, right? Because we know that even one failed intubation attempt significantly increases the risk for adverse events during airway management. And so the question I asked myself looking at this is not so much which method best gets the tube down eventually. The question is which gets the tube down first. On the first pass, the first time. And there was no difference between these two.
Yeah, and so take that, and then with that in mind, let's mention the other sort of big important meta-analysis, and that was from 1 year later. That was from 2017, published in the journal Critical Care. And in that one, they pulled data from 12 randomized controlled trials, about 2,000 patients in total. And in that one, all of the pooled studies were conducted in emergency departments or ICUs, and that was in contrast to the Cochrane review. And in this study, they found no benefit in video laryngoscopy over direct. So that's probably a little bit more like what we're looking for, isn't it, Jeff?
Yeah, I mean, I think that's definitely our patient population, and important to note, even in like the did subgroup analyses by location, and there was no difference in the emergency department subgroup analysis either in that study. And it's been criticized that the studies they looked at were pretty heterogeneous in terms of the patients they included, and several of them had some substantial methodological weaknesses, including potentially excluding difficult patients. But I think it still remains kind of the best prospective evidence we have to answer this question.
Yeah, I mean, it's the best we have, but like you're talking about apples to apples, that really seems to be the theme with the available evidence on this topic. The two big meta-analyses that we talked about, and most of the other literature too, by the way. There was another meta-analysis around the same time, which pooled 5 randomized controlled trials. There was a 2017 article that made it into JAMA from France that gets cited a lot. And there's been a handful of others in the last 5 years. But the consistent theme is that, for such an important matter as this, the methods used to study it really have not been as rigorous as we would like. They've not been that rigorous.
Yeah, I guess I don't know if it's not that they're rigorous, but it's just that it's a really difficult topic to study in like a randomized controlled fashion, right? Because it's hard to consent and enroll patients for a study when they have to be emergently intubated. I mean, generally they're not very communicative and it's hard to obtain consent from them. And there's this question too, when we try to sort of pool these studies together, of are we really comparing apples to apples? Because they're looking at several different device types across these meta-analyses, which might have some device-specific benefits that we're missing out on.
Yes, I mean, you're absolutely right. So it gets really clouded. This is it's a tough thing to study. For the reasons that you mentioned, and then also when you consider that just the act of intubation, the procedure itself is really hard to study. We're talking about things like time to intubation from when you begin the attempt, or hypoxia, and these things they're hard to study. So the saturation goes down to 78% for a few seconds. Does this count as hypoxia? Was the blood pressure cup off? Did the probe fall off the finger? It's just really hard to take rigorous measurements of these things during unplanned emergent procedures. So, look, something that we obviously agree on is that all of the research we've mentioned so far is sort of flawed. You know, looking at the left panel, it kind of gives this picture of, you know, nice intubating conditions that don't really exist in reality for us. So something I'd like to bring up is a more recent study from earlier this year, February, published in Academic Emergency Medicine. And Jeff, you and I disagree a little bit on this one, but I think that this one does the best job so far of studying the question of video versus direct in a way that replicates our real life practice in emergency rooms. It was an observational registry study, and it was done only in EDs, both academic and community, so good generalizability there. And they compared video to direct, and they used both hyperangulated and standard geometry video blades, and they did separate analyses for those. And importantly, the direct intubations were looked at sort of under real world conditions. In other words, they were trained operators, they were emergency residents and attendings, and they looked at them separately, and they allowed them to use a bougie if they wanted to use a bougie. If they did some laryngeal manipulation with their right hand, they looked at that separately, patient positioning, ramping, et cetera. In other words, the DLs that they looked at were done under sort of real world conditions. And their results were pretty convincing. They sort of resoundingly say that video wins. They say that you're 1.5 to 3 times more likely to have first pass success without hypoxia using video.
Yeah, this is a great effort, and I think the NEAR registry is probably the most robust sort of data collection on how emergency intubations actually happen in the real world. But like you said, it's a retrospective study, so there's always potential for recall bias, right? People are collecting all this data about predictors of difficult airways and how tough the airway was after they did the procedure itself, and sometimes, you know, several hours after the procedure. So recall bias exists. And I can't, you know, kind of get past the fact that I think these are really 2 different patient populations, right? They looked at people who had DL that required some sort of augmented maneuver as opposed to VL where they just, you know, did nothing except stick the blade down the throat. And though you said in the study they were essentially equivalent, if not the VL group was a little bit harder to intubate. They just sort of seem to me like very different patient populations. But regardless, I think this is a finding we see in most of the retrospective studies, is that sort of in observational studies, the video seems to do better, but that's not really been borne out in prospective research. And kind of the mantra in EBM is always that prospective studies, because they have a decreased risk of bias, really should trump or provide us a higher level of evidence than retrospective and observational cohort studies. And so I think we see, the way I read this is there's a strong signal in the data, but there's nothing definitive. And so we're at a point of, I think, essentially equipoise in this question.
Yeah, so, you know, I think it was brief, but I think that's a fairly honest tour of the evidence that we have so far. And while we disagree slightly on the recent NEAR paper in Academic Emergency Medicine, you and I, we definitely agree that the superiority of video or direct is not at this point firmly established by the evidence.
Yeah, absolutely. But I mean, we still have to make a decision, right? We have to decide how we're going to, you know, train and practice intubation in the real world. And so we have to rely sometimes on other things besides evidence alone. You know, there's, you know, pathophysiology and experience, and to some degree kind of, you know, art and I guess even philosophy of practice.
Yeah, and, you know, speaking to the potential conflict between, you know, the data that are available and sort of the philosophy of medicine, you know, to me, regardless of what the evidence might actually or eventually come out and decide on the superiority of video or direct, you know, my question is it irresponsible to hinge a patient's life on a piece of technology? You know, like we said before, airway management it's the most important single physical skill that we have as emergency doctors. And, you know, there can be camera failure. You can get blood or vomit or secretions on it. And that can just totally incapacitate the VL. Now, you're in a situation where you've just paralyzed a person. You've taken somebody who was breathing and you've made them not breathing with plans to insert an ET tube, and you risk technology failure. You're literally betting someone else's life that this equipment is going to work. And to me, that's really serious. And I think that we shouldn't necessarily be depending upon technology. It's just too important.
Yeah, that's a good point. I think that and we also want to be training people who can practice places where video might not be available, because it's not entirely ubiquitous across the world yet. And I think anecdotally, we can certainly think of cases where people have been impossible to intubate via video laryngoscope, and then were actually fairly easy via DL. And unfortunately, there's not a lot of data capturing kind of who this patient population is, but I think we'd all think of at least one or two cases of our careers where that's happened.
Yeah. So, okay. So those are the types of questions, guys, that I think exist outside of the evidence, independent of the evidence. And it's tough that we're not debating here per se, Jeff and I. But I will say this, that regardless of which way the evidence might lean, I think that we should not be abandoning direct laryngoscopy as a mechanical skill.
Yeah, I think that if there were overwhelming, convincing evidence of the superiority of VL, we have to do, as Dr. Scott alluded to, sort of what's best for our patients and keep that primary. But I think at this point that has not been shown, despite a plethora of evidence. So,
all right. So back to the initial question. How should we be learning laryngoscopy in New York City in 2020? You guys are residents training here. So we've kind of taken a survey of the literature for you guys, and it's not convincing either way in favor of video or direct. We've brought up some philosophical questions for you to think about independent of the available evidence. So I think now you guys possess the key tools that you need to think about where you stand individually on this debate. And we're going to tell you where we stand, because this is, where we stand, where we conclude, we agree on this.
Yeah, I mean, I think there's lots of right answers, but probably but I agree with you, Mark, that we do need to, at this point, keep up our mechanical skills of DL. And there is a way we can do that, potentially while not losing the advantage of VL also. And so, I mean, in addition to hyperangulated blades, we have standard geometry Mac blades. I think some people mentioned this in the chat to the panelists also, but there are standard geometry Mac blades that allow you as an operator to do DL while your attending can look at the screen and kind of give you real-time feedback and guidance. And that kind of makes sense. It's going to help you. And the literature supports the idea that having attending looking at the screen and kind of coaching you through the procedure increases your first pass success as a learner. And so I think for all of the kind of non-COVID airways, or at least most of them, that's probably the best way to approach learning laryngoscopy in this time, and probably also with the bougie, but we didn't really touch on that, but probably with the bougie as well.
Okay, so that's where Jeff and I come down on this. Just to kind of put an exclamation point on it, our position is that the way to proceed is with a standard geometry blade with video, so that you can have the mechanical skill of direct laryngoscopy and learn that, but without sacrificing the benefits of the video. So that's our verdict. And just one more thing before we finish that we both want to kind of convince you of is, with this issue, and probably with a lot of the others that we're going to talk about for the rest of the day, you guys may see yourself as sort of bear cubs in the EM forest. But everyone in this audience, all of you residents, you've got somewhere between 7 months and 43 months left in your EM training, and that's it. And then you're done. And it's really important that you understand that you are the drivers of your own education. It's you and not your faculty that are going to be the primary determinant on whether or not you learn direct laryngoscopy as a skill. I think every ED in the ALL NYC consortium has the equipment available to you. And it's going to be you guys who are going to decide the future of this DL versus VL debate. And hopefully we've done an okay job in, sort of arming you with a framework within which to think about it. So that's all we have. Happy intubating. And Jeff, it was a pleasure. Thank you.
Thank you.
Thank you guys for that awesome lecture. So now we're moving on to the panel discussion. We have some questions that we thought would be relevant to discuss. We also have some questions that opened up in the Q&A in the chat, so we'll be going through them. First, I'd like to introduce Dr. Odafonate. She is a Nighthawk attending at Harlem Hospital. She's also the director of podiatry student clerkship in emergency medicine. I know you are very opinionated on this subject. You work with residents. You also work without residents. So I guess the question after hearing this lecture is, are you doing DL or VL alone with residents? What's your take on this subject?
Pre-COVID, I was definitely for DL. It was, while we learned video as well as DL in residency, I would definitely say, at least my training was definitely more skewed towards direct. So I'm way more comfortable at direct versus video. During COVID though, that changed. In our department, we were fortunate enough to have anesthesia come down and do our intubations, and they were using a CMAC. In the event that, our attendings did need to intubate, we were in full PPE. We're still using P100 masks, not even N95s, full face mask, and depending on who was intubating during COVID, if it was the attending, depending on what they had at their, what they had available, some were doing direct, some were doing video. As for me, even during COVID times, I still feel more comfortable doing direct. I feel like that's the fastest way I can get a tube in. But if I'm working with a resident, I tend to lean towards video.
And I definitely think that's a good point. It was brought up in the chat as well. It also depends right now, practically speaking, the patient in front of you, what are you comfortable with? And a lot of attendings are more comfortable with direct. So the goal is to get the tube the fastest, safest way possible. And for some people, it might be direct. But I guess the question for the group is, if we have N95s and face shields and P100s, and we also don't know who has COVID anymore, right? We have reinfections, we have people with atypical presentations, people who don't come in with any history. We still are assuming everyone is COVID. So how are we intubating, and why should COVID change that if we technically have all of the protective gear? This is for everyone on the panel.
Yeah, I think that it kind of just, there is some truthiness, sort of makes sense, the idea that if you don't have your face in the direct line of sight of the patient's face, that you're at a lower risk despite all of the PPE. I have not seen any data that really supports that, but it kind of makes sense. And I think there are a couple of questions there. One is, as educators, we're obligated to keep our trainees as safe as possible. So there's any possibility that doing VL is safer than DL. I think having trainees do that, it makes sense from that standpoint. But again, I think that's more of there's no strong data. The only thing I've seen is that in simulation studies, they actually measured the face distance of people in VL versus DL. And so you get about 6 inches more distance and out of line of sight in VL. So I think that's an argument for VL in those situations. But the other thing is, like you said, some people are faster with DL. And there is some comment on the chat about sort of VL is faster. I think that's actually in the literature not up for debate. In many studies, VL actually took longer than DL. And so it's not clear which one's actually a speedier way to intubate. But I think you're right. It might depend on per provider. Everyone's going to have different rates of first pass success with different modalities. And so it does make sense to stick with what you're most comfortable in these sort of high stress, high risk intubations, I think.
And also, we mentioned, so 6-inch difference to me is not a ton of difference in terms of, am I getting COVID from this patient or not, if I'm not properly protected, right? But most of us, almost all of us on this panel, work with residents. We're leadership in our departments, and COVID's going to be around for a lot of our residents training. I mean, it's been going on 6 months. It might be going on another year. I'm at a 3-year residency, so I can't afford to let anesthesia always intubate, or to let my residents always do video laryngoscopy. So how do you guys take the information that was presented in the lecture that you know, practically speaking in the ED, and make the best decisions for your team? Because COVID's here to stay for a long time.
You know, I think the silence after you ask the question is really telling. And you know, this is the lamest answer that you can think of, but it really, I think, is a case by case decision. It's going to depend on who the learner is, who the patient is, and who the faculty is guiding it. You know, as we said, generally we've shifted. Most places have shifted to all video all the time. But you know, you bring up a great point. All video all the time for your entire residency means that this is a skill that generations of EPs before you have had, and you've been deprived of. You know, and I think it's, for the residents in the audience, I think it's kind of telling that, you know, several of the attendings in this panel have mentioned, oh, you know, I like to do DL in these situations, or this is why I prefer DL as my first choice. And, you know, regardless of what you think of the merits of what their decisions are, you must at least acknowledge that there's a certain benefit to having that option available to you. You know, if you go for your whole residency and never experience DL, you will be an attending and you won't even have the luxury of that option.
Yeah, and you know,
agree with that. Yeah.
I wanted to send it back to you, Dr. Odafonate, because like I said, you know, you work overnights where there's less coverage, you work with residents, you work without, and a lot of our residents who graduate from here are going to work at single coverage places. There may not even be anesthesia as backup. And we all know that you cannot intubate a varicose bleeder with video laryngoscopy. It's not going to happen. So what are your thoughts?
At least when it comes to the more senior residents that were training pre-COVID and got used to dealing with direct, a lot of them even feel more comfortable doing direct over video. So I try to, if that's what they feel more comfortable doing, that's what I let them do first. Mainly because, like, you know, I think it's great to hone in on a skill that you're better at. But having said that, I guess what worries me is our interns or our second year residents that got caught up in COVID, like the second half of their intern year, or, you know, the beginning of their intern year. And the fact that in their learning, it's more video than direct. I saw in one of the actually my old program director, Dr. Pereira, Tom, had mentioned something about, you know, using video just to get used to the anatomy and then eventually going to direct. So like you have more, at least I believe that's what he said. So you have more of a sense of what the anatomy is supposed to look like. And I think that that's at least when I think back to when I first started intubating as an intern, I think that was the biggest thing for me, getting used to what the typical anatomy is supposed to look like. Because, you know, when you do it via like sim, like all of those are just perfect pictures of what cords are supposed to look like and stuff like that. And we all know that in a real life situation, that's not how it is. So I do think that at least starting off via video, especially with our interns or second year residents that haven't gotten as much exposure to direct, starting off with video, just so you have a sense of what the anatomy is supposed to look like in a real patient, and then pushing them, you know, as long as it's within their comfort level, to try direct. And clearly if they're having difficulty, you know, either switching to video or the attending taking over.
You know, and I think that's a good thought process and a good approach, is maybe get used to the anatomy with video and then move on to direct. But what that means, well, so first of all, I think there's a common misconception with residents that if you can intubate with video, you can't intubate with direct, or vice versa. It's different technique, right? It's completely different technique, the intubating, and not everyone realizes that. Or even people who've never done video, senior attendings who are now learning video, it's a different technique. So it's hard to just transition over. And then I think it's good advice, but I think then the residents are going to have to take the ownership to make sure, okay, what am I more comfortable with? What have I been intubating with? And if I'm really comfortable with video because I'm an intern or I'm a graduating intern going into PGY2 and I've always intubated with video, I have to push to get direct. So it's definitely will come up to the resident themselves to push and advocate for their education. But then it's tough. Some of us might not be comfortable letting people do direct nowadays. So, and again, I think the biggest overall message here is we need our patients to be safe. And I personally feel that the safest thing is for physicians to know how to intubate in every different manner. And you have to protect yourselves. We have the personal protective equipment available, thankfully, but we have to graduate residents who know how to intubate with DL and VL.
Yeah, I think that you mentioned that about the technique is really important, and that even within VL, the techniques are a little bit different between the hyperangulated blade and the standard geometry blade. And I think this using standard geometry gets you a lot more of the same, having to exercise good soft tissue control and get some degree of line of sight that more approximates, even if you're using it primarily as a video methodology, it approximates what you do with DL. And the two major systems both have standard and hyperangulated blades. And to think that training as much as you can with whichever system, a standard geometry blade, whether it's primary video or direct, is gonna be more crossover between those skills than if you're doing all video hyperangulated blades and then try to learn to do direct from that, or even vice versa.
Now, Dr. Odafonate, I know you're more comfortable with DL generally. So for Dr. Almonte and Dr. Corrado, when you are intubating without a resident, do you have a preference direct and video? And do you have a preference for your residents? Today, down in the ED, a patient comes in and you have to intubate. Does it matter if you're intubating by yourself or with the resident?
Yeah, I guess it matters. Generally, I don't have a good defense for what I'm about to say, but generally I do direct laryngoscopy first. It's just what I'm more comfortable with. I'm getting increasingly facile with video, but when I'm intubating by myself, it's usually direct. As is more often the case, though, as we all know, we all work in the same places. Oftentimes when the attending gets to intubate, I'm like third online. It's the junior fail, senior fail, attending, and now it's bloody and edematous. So in those situations, I'm one guy, N of one, but in those situations, if the resident was having a difficult time with visualization, then I will often switch to whatever they weren't using. But if the resident was using video and there was good visualization, and for one reason or another they weren't able to pass the tube, a lot of times I'll stick with that, if the blade's already in the patient's mouth. But I'm just one guy interested to what others have to say.
Yeah, I do this. I think I'm probably the same way. If they were doing video and they saw the screen and just couldn't pass the tube, saw the cords on the screen and couldn't pass the tube, I'll usually pick up the video. If I'm starting off on my own, I will pick a standard Mac blade with video, and then usually do DL with a bougie using that. And if I have problems, then sort of transition to video in the same attempt.
And there's been a lot of chit chat on the chat talking about how now we have video. So we have, let's be clear, video laryngoscopy means you're looking with a video to see the cords. You're not looking directly in the cords. But we have different adjunct devices like the CMAC, where the resident is theoretically going in via direct. The attending can watch, and you talked about it in your talk, right? But not every video laryngoscopy has the same type of blade. Some are hyperangulated, some are not. So there's been a lot of chatter about, well, if you have a direct laryngoscopy blade attached to a video, you can have the attending teach the resident direct laryngoscopy. So yes, that would probably, I think we all agree, would be the ideal scenario, is you continue to teach direct. We can watch. Not every place has that as well. I think it's important to remember, you also have to learn how to use a hyperangulated blade, right? So it's not just abandon the hyperangulated video blade altogether. You have to know how to do every sort of different technique. But I do think we probably all agree the best scenario would be direct blade with the video, do CMAC, I can teach you, and you get all of your skills up. But we're not always going to have that, and half the time the equipment's broken. So I think that's important to remember. There was one quick question, and I don't know if you, Dr. Corrado and Dr. Almonte, have the answer. Is there any literature on bloody airway? Which one is better? I mean, it seems like we all anecdotally, I know that I can't intubate with video if it's a very bloody airway, but is there any literature on that? Or is it just common practice?
So there's a group in Phoenix that has a big airway registry. They've done a bunch of retrospective studies. And they looked at people with contaminated airways and found that there was equivalent success with VL and DL in their contaminated airways. I can point out in their studies, their VL success across all their kind of published study, or DL success, sorry, is much lower than kind of the sort of what we accept as standard first pass success. So I think that's one of the institutions where it seems like their DL performance just isn't quite as good in what they've published and what we might expect based on historical controls. But in their published study, there was no difference between the two in contaminated airways.
All right, awesome, guys. So I think that's all the time we have for the panel discussion. Dr. Odafonate, thank you for joining us. Thank you for a different approach than our lectures that we had up here. And we're going to move on to the next topic. Thank you, Dr. Almonte, Dr. Corrado, and Dr. Odafonate.